It is wonderful to have summer in September. And it is also excellent that you have all joined us today for this very important topic, opioid concerns, opioid crisis in America, and opioid epidemic here in Michigan and everywhere. And it is my pleasure as Director of the University of Michigan Lansing Service Center to welcome you and to note that the University of Michigan sponsors these forums thanks to the Office of the Vice President for Government Relations and the UM Alumni Association. And we like to think that we're helping to improve life one forum at a time. And we have today a group of distinguished panelists who've come to talk about this crisis. And introducing them will be the Honorable State Representative Yousef Rabhi. Representative Rabhi represents the 53rd House District in the great city of Ann Arbor. He is an alum of the University of Michigan. Go Blue. Go Blue. And without further ado, I'd like to turn it over to Representative Rabhi. And I also want to mention, for those of you who use Twitter, there are hashtags that we would recommend you use, and those are right on the handout table. So, Representative Rabhi, thank you.
Well, good morning, everyone. How are you?
Good morning.
Good. First of all, I'd say let's give a round of applause to Veronica and Rebecca and the entire team at Government. They do awesome work. I can tell you as a legislator and as an alumni, they represent us well. So thank you for being here today. This is a very important conversation, and seeing so many faces here reflects not only the importance of the conversation, but how engaged we all need to be in solving this epidemic. We're here today because this is an epidemic. Because we have, in Michigan, 4 people dying every day. Every day. Because of this epidemic. It is an epidemic that we can address. It is an epidemic that humans, we in this room, have the collective power, the collective intelligence, and the collective will to address head on. For too long, it's been relegated to the shadows. For too long, we have said, those who are suffering need to suffer alone. But recently, we have been bringing this issue out of the shadows. This is not, well, in a time when partisanship has gripped not only our government in Lansing, but also at the federal level. This issue shines through. It doesn't matter if you're a Republican or a Democrat. This issue transcends political boundaries. And so now is the time, even in the most divisive political environment, now is the time to be having these conversations, to figure out how we're going to solve this problem. Because we owe it to our fellow Michiganders and to our fellow Americans to make sure that we're standing up for them. Whether we have a family member or not who is suffering with addiction, we have an obligation, a civic duty, to stand up for those that are. So without further ado, we have a very distinguished panel of guests that we're going to hear from today. The moderator, though, for today's conversation is John Ayanian, who is the director of the University of Michigan's Institute for Healthcare Policy and Innovation. And I would like for us all to welcome him to the podium as he begins today's session. Thank you all for having me.
Thank you, Representative Rabhi, and thank you all for joining us today. It's our pleasure from the Institute for Healthcare Policy and Innovation, in partnership with the University of Michigan Injury Center and the Michigan Opioid Prescribing Engagement Network, major organizations on campus at the University of Michigan to come together and to share some of our insights from the work that many of our colleagues across the University of Michigan have been conducting on what is one of the most challenging public health issues of our day, the opioid epidemic, and the health and other concerns that it's creating across our state and nation. We have 3 outstanding speakers who are bringing their expertise to share, and we hope to learn from you and your perspectives. We'll have each of our speakers give approximately 10-minute presentation, and then we'll have about 30 minutes for questions, concerns, comments, discussion, and we look for a very interactive discussion with you about this important topic. So I will briefly introduce the 3 speakers, and then they will each give their presentations, and we'll return for the discussion period today. Our first speaker is Amy Bohnert, who's the Associate Professor of Psychiatry and an investigator at the Arbor Veterans Administration Hospital. She's an opioid overdose content lead for the University of Michigan Injury Center. She provides guidance to the Centers for Disease Control in opioid prescribing guidelines for chronic pain. She's collaborating with Michigan Medicine, the State Department of Health and Human Services, and Community Mental Health to improve access to medication-assisted treatment for people with opioid use disorders. And she'll be discussing trends in opioid prescribing and overuse, state and national level research and policy related to prescribing and treatment. Our second speaker will be Dr. Rebecca Cunningham, Professor of Emergency Medicine and Associate Vice President for Health Sciences in the University of Michigan Office of Research. She's the director of our CDC-funded University of Michigan Injury Center that focuses on opioid overuse and overdose prevention. She's also a gubernatorial appointee on the Michigan Prescription Drug and Opioid Commission. She'll be discussing some of the important policy efforts related to opioid prescribing and use, including our Michigan Automated Prescribing System, or MAPS, and ongoing efforts to improve surveillance for fatal and non-fatal overdoses. And then our third speaker will be Chad Brummett, Associate Professor of Anesthesiology. He's the co-director of the Michigan Opioid Prescribing Engagement Network, or Michigan Open. And he will be discussing the work of Michigan Open, particularly raising awareness among patients and providers of the risk of opioid dependence following acute care, such as surgery, dental procedures, emergency medicine, and trauma. Also measuring and reducing excess prescribing of opioids by clinicians providing acute care, and improving our system for disposal of opioids statewide. So please join me in welcoming our 3 speakers and Dr. Amy Bohnert to begin.
Introduction. I'm going to, since I have the honor of kicking us off, I'm going to give a little general background that'll be relevant to all 3 of our presentations and hit on some of the interests that Rebecca and Chad and I share. And then I'm going to talk a little bit about medication-assisted therapy for opioid use disorder, since I'm in the Department of Psychiatry. Treatment for addiction is one of my core interests. To start very broad, I thought I'd just go ahead and define what prescription opiates are. So these are medications that in the U.S. require a prescription from a doctor. They are scheduled on Schedule 2 or 3 by the DEA. So they have a lot of special protections around how you can treat with the doctor. These are medications primarily used for the treatment of pain. So this isn't based on any data in particular, but I just wanted to conceptually talk about how they're used. So probably most opiates in the U.S. are prescribed for pain treatment and used to treat pain, not used for any other reason. But it's important to acknowledge that there's a separate kind of use. So people obtain them maybe from a doctor and save them, use them later. They might get them from a friend. They might buy it from a dealer. All are behaviors that I would call non-medical use. And it's also important to acknowledge that there's overlap between those two. There are people who get an opiate for a true pain condition and have a pain condition they need to treat, but are sometimes using more than prescribed or using in ways that might cause harm to them. So they fall somewhere in between use for pain treatment and what I would call non-medical use. The CDC has described this as an epidemic for the last couple of years, and these are the data that led to that designation. So these are overdose deaths due to any substance over the last, over a 15-year period or so. And you can see that this blue line, the overdose deaths, I apologize if the text is a little small for the folks in the back, but the blue line represents the number of deaths due to unintentional overdose in the U.S. In contrast, the pink line is deaths due to motor vehicle accidents. And you can see that that overdose deaths actually overtook motor vehicle accidents as the leading injury cause of death in the U.S. just for context, I also put on this yellow line, which is unintentional fall deaths. Perhaps that'll be a later form, because there's a lot of interesting things going on there as well. This data is looking at the same overdose deaths, but broken down by the specific types of opiates involved in the death. So these aren't ideal categories. These are what medical examiners have to work with for classifying it, so it's what we have available for doing surveillance. You can see the green line is all opiate deaths. That's much sharper than the all overdose deaths, so a lot of the trend that we see in all overdoses is driven by the opiate-related deaths specifically. All the other substances have pretty much stayed stable. A couple other things to note is this blue line that's shot up in the last couple of years, that's heroin-related deaths. So a separate but potentially having some related problem is the increase in heroin overdose deaths that we've been seeing in the US, as well as the orange line, which is under other synthetic opiates. That category, again, not ideal in terms of how it's classified, but it includes fentanyl-related deaths, for fentanyl that's not being used for medical care, but that's being sold on the street and cut with heroin, and that is particularly deadly, and unfortunately cheaper than heroin, so that's why it's being used to cut heroin quite a bit. We're going to talk some today about opiate prescribing and how improvements to opiate prescribing could help address this problem. And I wanted to talk a little bit about why there's been a focus on prescribing. So this was the first peak that got people, this type of data was the first peak that got people thinking about opiate prescribing as it may be driving the opiate overdose problem. I'm not going to talk too much about the reasons for why opiates became prescribed so much. That could perhaps be saved for the Q&A if people aren't familiar with some of what was going on in medical care in the early 2000s. But in the later part of the 2000s, people were noticing that this increase in opiates use for pain coincided with an increase in opiate-related deaths. So that's at a very broad population level. There have been a couple studies that have occurred since then that have brought that connection between opiate prescribing and risk of opiate death to a more individual level. So in a study of people who died of an opiate overdose in West Virginia, they found 44% people had a current valid opiate prescription at the time of their death. So suggesting that they were in medical care, whether they were using it appropriately or not. Clearly there was a physician who they interacted with who had some opportunity to talk to them about their opiate risks, and was likely a missed opportunity. Other studies have, in more recent years, have actually found that proportion with the valid prescription to be higher. The other data point here, so 86% of people entering addictions treatment for treatment of a prescription opioid use disorder said that they started using opiates for pain. So not that they got it from a buddy and it was fun, not that they bought it from a dealer, but they were first introduced to the drug through getting it for pain and medical treatment. Some work we did at the University of Michigan with data from the VA showed that patients who were prescribed higher doses of opiates compared to lower doses of opiates were at greater risk of dying of an opiate overdose. So furthering this idea that the more access you have to this, the more medication you have on hand, the more risks that come with that to the individual, and the likely connection between what you're being prescribed and the opiate overdose epidemic. Now I'm going to pivot to talking about opioid use disorders and the treatment for a minute. So the gold standard of treatment of opioid use disorders is medication-assisted therapy. And the reason why I say it's the gold standard is because I may be exaggerating a little bit, but basically every study that's ever been done comparing these medications to treatments that do not include that medication, so things like 12-step alone, other abstinence-only forms of medications, the medication has much better results for people on average. So there are some people who can stay clean from opiates without them, but by and large, if you take a group of people and put them on these medications and you compare them to people without, the group who are on are much more likely to stay abstinent. A recent study that made that comparison found that 80% of people who were abstinent 18 months later if they were on the medication, compared to 37% of people without it. So they're a pretty core part of effective opioid use disorder treatment. There's two main medications on the market for this. One has been used for decades, that's methadone. That's used primarily in traditional addiction treatment settings. Require an addiction psychiatrist to be there monitoring the methadone, require daily visits. Suboxone, which is a brand name for the combination of buprenorphine and naloxone, is a newer medication. Physicians just started being able to prescribe it outside of addiction treatment settings in the year 2000. And that means that any physician who obtains additional training and applies for a waiver. And the reason why they use the term waiver is because you're waiving the requirement to treat opioid use disorders in addiction treatment programs. So they're able to do it in a primary care office, and family medicine practitioners can do it. Really, any physician can if they obtain this waiver. So there's a lot of potential for overcoming some of the workforce barriers because there's a limited number of addiction psychiatrists and people going through that specialized training. However, there's a lot of barriers to the widespread use of these, and stigma is a big factor. People say that if you're on these medications, you're not really clean, you're still dependent on these medications. We could get into the reasons why that's not true, but it's not true. And we could maybe talk about that more in the Q&A if there's interest in that issue. There's also reimbursement barriers. So I was talking to a physician from Grand Rapids on Friday who is an addiction medicine specialist, so she's internal medicine and got the additional training, Suboxone training. She said she's been under pressure to not do as much of this because it does not make as much money for the health system that she works for to do this kind of treatment as opposed to her regular primary care practice. This is some data put together by SAMHSA and some folks at the Health and Human Services to look a little bit more at these access issues. So the top line there is the number of people in the U.S. who have an opioid use disorder. You can see, not surprisingly, with all the things that are going on with opiates, that number has increased dramatically over these years. The bottom lines here are the amount of people who could be treated for opioid use disorders in this country with the current workforce we have for it. So you can see the number of people who can prescribe buprenorphine excuse me, has gone up as the policies have changed, allowing more people to prescribe buprenorphine. However, it still lags well below the number of people who need treatment, unfortunately. And the stable line at the bottom is the number of people who can be treated in methadone programs. Sorry, getting over a cold. This is some data from Baltimore, where the city paid for physicians to obtain the training and get the waiver. So this bottom line here is the number of physicians prescribing buprenorphine. As that went up, the number of people dying of a heroin overdose went down. Sorry. For the last minute here, I want to talk about some programs, newer programs we have starting up here at Michigan. So this is the Michigan Opiate Collaborative. This is funded through the Michigan Department of Health and Human Services. We can get into the details a bit more if we need to, but the core thing is that it's providing peer mentoring to physicians who are interested in starting to prescribe Suboxone from experts in providing that treatment. The other program is a injury center funded project that we did a brief intervention in the emergency department where we found that people who talked to a therapist about their opiate misuse had lower levels of opiate misuse and lower overdose risk behavior 6 months later compared to people who did not. And right now we're doing am I not close enough either? Just to soften the coughing for everybody. We're currently working on a translation project to, instead of having research therapists do that, have a toolkit so that therapists in actual community settings can use that intervention. And with that, I will hand over to Rebecca.
Thank you all for the opportunity to talk today. As Dr. Ayanian mentioned, I direct our CDC center here on campus. I'm an emergency physician by training, and I've been interested in opioid use as a long-standing issue as we see our patients, as someone who prescribes these medications, as someone who sees people coming in with acute pain who need pain management, and as someone who's treated and done research of public health interest in substance misuse and diagnosis for many years. At Michigan, we have one of the 10 funded CDC centers in the country, so many of you who are involved in this epidemic know the CDC has been very involved in pushing out guidelines and information and prevention, and we're fortunate at the University of Michigan and the state of Michigan to have one of these 10 centers here in our state and on the U of M campus. We really have a team approach to injury prevention and to opioid misuse, and we have over 400 members. We have folks from all across the schools at the U of M. We have folks in the, in the School of Public Health, in the medical school, the Transportation Research Institute, nursing, the pharmacy school, the School of Policy. So we pulled together expertise across the campus on multiple topics. Specifically, one of our focus areas, we have several focus areas, one of our focus areas is opioid misuse. We also have partners with, I see some of the state health department folks here, with the state health department, as well as with our law enforcement partners, the high intensity drug trafficking folks. The core issues that our center is focusing on in terms of solutions are, I'll talk in a minute about a real-time surveillance system. We're engaged in a number of other ways in this topic. I'll try to talk closer to the mic, including policy analysis of laws that are passed and whether those are having an impact or not, identification of opioid expertise locally. Some of you have that handout with the little pills on the front, which shows many of the folks in network across the University of Michigan who can serve as a resource on this topic for you. We facilitate partnership and funding for the translation of interventions, such as the one Dr. Bohnert talked about, looking at PDMP mandates, and much, much more. So I want you to, this slide comes as no surprise to probably most folks in the room. It's difficult to read, but darker red is worse. We all know where Michigan sits on the map. This is data from 2015, and we can see that we have a problem, obviously, in the state. These numbers are up 13% from the year before that we measured. And the reason I'll draw your attention to this is these numbers are from 2015, and the reason we can't present you 2017 data is we don't have 2017 data because, like many states, the data collection resources that we have and sources don't provide that kind of real-time update. So what does that mean? That means many of the bills that are going forth now, many of the interventions that we're working on, will be several years down the road before we're able to know where we are for surveillance. Surveillance of what? For how many people have died this month, this year, this week. Our law enforcement professionals would like to know how many people have died this week in a particular county or region. Public health would like to know, and really needs to know, how many people in a particular section over the last month or two have had both a fatal overdose and then a non-fatal overdose. So this is a gap we've identified with our partners that we're working to improve on. The current state of surveillance in Michigan is there's multiple sources for how we know who have overdosed. We know because the medical examiners tell us somebody has died. That source is decentralized in Michigan, and that data is then recorded not all electronically, individually from the individual counties. So a decentralized system is one of our issues. Emergency departments right now don't have a clean way to report centrally how near fatal deaths are happening. Why do we care about near fatal? Or shouldn't we just be worried at the most worst? Because people are often having 3 and 4 non-fatal overdoses that they're being recovered from with naloxone before they have that final unfortunate episode. And if we could find out about that and track those in a closer system, then we could get earlier on and prevent the body count that is happening later on down the road. And then we are able to use EMS data that is statewide, and that is a benefit. Other states are a little bit ahead here. The state of Massachusetts is a real example. They connect 10 data sets to analyze services by individuals who had an overdose, both fatal and non-fatal. North Carolina have their emergency department and medical examiner data updated daily. These are places we feel we can improve on and things that we are working on. In partnership, when, as many of us have come to realize this is a problem, We've worked at the Injury Center with partners. Some of you may recognize here the logo of HIDA, which is our High Intensity Drug Trafficking Association, or area colleagues in law enforcement. We have partnered with them over the past year to develop a surveillance system, which we're in the pilot and early phases of and are rolling out, which connects public health and public safety, identifies real-time surveillance and hotspots. Hopefully that can then inform law enforcement and public health. We're working to connect medical examiner data from about 50% of the counties in the state to develop an online system that we hope will be modeled on the Michigan traffic crash fax system, which allows you to go online and query in real time where events are happening. Obviously, we will release information in an area that is de-identified enough for use both by whether you're a public health professional or law enforcement, and or some of this will be de-identified enough to be allowed to be released to the public without worry of compromising individual information. We're prioritizing right now as part of a solution to this problem, the 11 high. For that patient I saw, Nancy, that young mother, am I mandated to go and look into the MAP system? The blue are the states where it's mandated. The yellow are the states that we are not mandated to look currently. So just a quick example before I wrap up. What has worked in other states? I'll point you to the Kentucky example, which implemented a PDMP use and a registration mandate. It allowed providers to free up their workload by allowing delegates to help prescribers check into the MAP system, have my physician assistant or a pharmacist look into it, bring me back the information, so as a busy physician seeing patients, I would take a little bit less time, help me fulfill that mandate requirement. It's utilized input from prescribers, so we've got a lot of information on what works for prescribers, how they would find the system useful, really got their buy-in so that they would use it. What did it result in? PDMP queries increased by over 500%, registrants increased by over 70%, 95% of in-state practitioners with the authority to prescribe became PDMP registered. And most importantly, Kentucky experienced a significant reduction, with a 16% relative reduction in the number of opioid prescriptions filled. I'm not sure if that's me or not. So what do we know about PDMP effectiveness? We know the use of mandates by prescribers decreases opioid prescribing, decreases measures of doctor shopping, decreases overdoses in especially adults and the elderly. Registration mandates, we find similar decreases. Key features we talked about a minute, combining both the mandate for registration with the mandate for use. Having that administrative support to help busy physicians actually take the time to look into it. Working with prescribers so that they can understand why it's important for them to go into the system and what to do with the information after they get it. And then also, it's really important for the data to be useful in maps to a wide variety of folks. We have laws here in Michigan that other states don't have, that the MAPS data cannot be shared easily with public health professionals or with public health researchers. Making that easier in our state would help us all address this crisis. And I'll end with that, with some resources for our center we can talk about. Only 2 minutes.
Good afternoon. Good afternoon. So I'm Chad Brummett. I'm an anesthesiologist. I'm a pain physician. I'd like to briefly introduce my colleagues. Co-director Mike Inglesby, transplant surgeon from the University of Michigan, Jen Walge, plastic surgeon, hand surgeon, and our program manager, Caitlin Culso. So the real workers are in the back of the room. So we've talked a lot today already about chronic opioid users, medication-assisted treatment, addiction services, super important. I'm a chronic pain physician. When I go to the clinic, this is stuff I deal with every day. But as a group, Michigan Open pivoted a little over a year ago and said, what about this first experience? What about that patient coming in not using opioids? Really hasn't been a big part of our conversation so far, right? When I said opioids today, how many of you walked in and said, I wonder if they're going to talk about the person not taking pills? Really isn't a part of our focus, and especially as we think about surgical care. Well, in surgery, that's probably about 70 to 80% of the patients, depending upon the case we're talking about. So it's actually the majority of the patients coming through. Well, does it matter? If we go across different surgical conditions, this representing sort of a mix of abdominal surgery conditions knee and hip surgery, hand surgery, pediatric surgery, this is cancer care, breast cancer surgery. If we went across, you'll see some range of between 6 and 19% of people not using opioids in the year prior to surgery who continue to refill opioids long past what would be deemed normal surgical recovery. Right? And I'll call that new chronic use. And I'm not saying it's addiction, but I will tell you that that by itself is associated with morbidity. That is a sicker patient at the point at which they become a new chronic user. And at 100 million surgeries per year, this matters. Right? So, and what's interesting about this is if I compare it to my everyday care in the pain clinic, taking care of that patient who came in not using opioids and helping to shepherd them through a path and ensure that they don't go down that path of chronicity, it's an important opportunity, and it's a fixable issue. We hear a lot, in fact this morning I had some great meetings with representatives, well, surveys are important. This idea of satisfying patients is important. And so providers prescribe to make their patients happier so they'll fill out the surveys nicer. This is a nice figure that shows absolutely no association, zero association, between the number of pills prescribed after abdominal surgery conditions and that patient's satisfaction with their pain score using the HCAP measure that was once tied to payment. No association. What matters? Am I nice to them? Do the nurses and the medical assistants call them afterwards? There's a lot more that goes into satisfaction. The idea that you're going to make people happier by prescribing more pills just isn't found in the science. Well, why else do we prescribe? We say, well, I can't, my clinic's burdened, we're busy, we're short-staffed. And if people call my clinic for refills, it's going to shut me down, it's going to break me down, right? This is another completely null finding. This is a flat line using a whole mix of surgeries. There is no association between the number of pills prescribed, ranging anywhere from 6 pills to more than 60 pills, and the likelihood that that patient refills the medication. Is there a basement? Probably, right? But it didn't matter if we looked at the individuals. We say we did 60. That was kind of half full. But I'd say it was a beautiful story. 15 pills. And what's cool is even after our intervention, this is maintained. So where do we take this? What's even cooler about these data, there was no change in refill. 4% beforehand would call for, we're leveraging a unique structure of Blue Cross Blue Shield funded collaboratives. Something that makes Michigan unique and ready to tackle this problem as we think about acute care prescribing. I'll show the CDC mortality map, and I'll show you HOPE, because on top of that, I'll lay the 73 hospitals from this one collaborative. This is a general surgery collaborative representing every major hospital in the state of Michigan, coming together 3 times a year to talk about quality. And we feel very fortunate. We went to Michigan Department of Health and Human Services a little over a year ago and said, we would like to superimpose an opioid narrative on top of this really rich structure and talk about better prescribing. So I'm excited. Next week, we're going up to Boeing, and we're going to put out some prescribing recommendations. Heard a lot about prescribing limits today as I've met with people. They're important. They're an interesting topic. These are lower than all the proposed prescribing limits, and they will actually reduce prescribing. And our new challenge is that a lot of these medications that people are overdosing on, heroin, but now fentanyl and carfentanil, things that were used to come out of the hospital system, but now are being made in labs around our state, not legal labs. They are so potent and so fast-acting that that's the major difference. So you take a pill, it's a slower decline. These injectables lead to a much faster decline, and so sometimes people just aren't resuscitating in time.
Great. If you'll hear the answers in the back, great. Please.
Hi, Vince Bohnert. I'm an oral surgeon in East Lansing, and I have a question for Dr. Cunningham about MAPS. I routinely MAPS my patients now, especially since I'm on your PDOIC committee. And I just want to know when Michigan's going to really get serious about cracking down. Because last year the stat was 26 physicians had their licenses pulled because of over prescribing. And I routinely MAPS my patients, and I will see 1 or 2 a week that's getting 120 Norco, 240 Norco prescription every month for the last, as far as I can go back. And to me, that just, I can't imagine a situation that would qualify for that.
To educate, we have spent, when I trained, when many of us trained 20 years ago, it was very difficult to write narcotics. We wrote them on triplicate scripts, and we were trained that these were dangerous medications. That changed dramatically over the subsequent 5, 10, 15 years, and we now have an entire generation of prescribers who were taught actively that they needed to, that they didn't prescribe pain medication, they were mean, bad doctors, that these medications were safe, and that we needed to give them much more liberty. And now here we are. And so we now have education in front of us to teach the habits that we've taught for prescribing to our young residents and trainees for 15 and 20 years, to teach them that these medications have substantial risk, that we don't know by any one patient what their risk is until we really look at the objective data and check the maps in front of us, because this epidemic doesn't have a clear socioeconomic race class issue. It crosses everything, that we need to check maps, use the objective data that's given, and then recently you've seen from maps, and many individual practices are giving feedback to providers, because I think most providers want to do the right thing and take good care of their patients, but they also may not realize where their patterns fall compared to their peers. And they need to be educated where they fall, and then what safer prescribing is, hopefully with the kind of data that Emma is putting forward.
And I'll just say that the only other thing I would add is that within the surgical prescribing, one thing we heard this morning was, there's the top 25% of bad players, or 10% or 5%, whatever it is. When we look at surgical prescribing, and Jen and I wrote a grant around this, in hysterectomy population, even the lowest quintile, the lowest group of prescribers as we categorize them, we're overprescribed way and just don't know how to do it right, because frankly we haven't given them the information to make those decisions. Oral surgery and dentistry are very interesting and certainly a part of our focus. We're just kind of delving into that area.
Please.
I've had injuries and things that required sometimes some narcotics for pain management. One in particular, I really wrenched my knee bad, and I had an option though.
I think it's a critical question. Congratulations to you for handling it the right way and making that decision, because it's not just the access, it's also the personal responsibility and that plan. Access is an issue in terms of physical therapy is not cheap. It does take time. But I think you even have to go broader. I mean, there are behavioral therapies when we think about chronic pain conditions for which we struggle.
Have higher rates for a number of reasons that may have to do with drug trafficking, or may have to do with how initial states' response was in the pieces. But the message across all those states is they're all quite high. We're seeing this isn't an issue in just the Northeast or just the Southwest. This is an issue across the country. And now it's up to the states of how we respond.
I'll show you the box of where we were. It looks like we missed the mark, right? A lot of people using nothing. Median, which is probably the best measure here, was 6 pills. Mean was 10 pills. And so we had a really bright, ambitious medical student, now and a surgery intern, put together guidelines in a voiced-over video and just said, let's just get smart. Let's do 15 pills. Very conservative, right? I said 10 was the average, 6 was the median. Let's just drop from 50 to 15. Let's encourage things like acetaminophen and non-steroidal medications, and let's educate you. Surgery can hurt. And it's okay. You're not supposed to be pain-free after surgery, right? Yeah. We're trying to make you comfortable. We're trying to make you functional. Well, here's prescribing beforehand. Any guesses on how we did afterwards? 50 pills on average beforehand? Any sense? So I heard somebody say we did 60. That was kind of half full. But I'd say it was a beautiful story. 15 pills. And what's cool is even after our intervention, this is maintained. So where do we take this? What's even cooler about these data, there was no change in refill. 4% beforehand would call for refill, 3% afterwards. No change in self-reported pain. And what's really cool is when you give people smaller bottles, they use less pills. Now, I was surprised by this. I work with a social psychologist. He said, Chad, this is easy. This is social psychology 101. This is called anchoring and adjustment, and this is largely rooted in the food literature. If I give you a bigger plate of food today, you're going to eat more. If I give you a bigger bottle of medication, you're going to take more. Okay, and this has not only been shown in our study. Cesarean section patients, women, in a very vulnerable state, if you give them a bigger bottle of opioids, they take more, and they have the same pain scores, same satisfaction. That was stuff that came from Harvard. So if we think about it, about 370 patients post-intervention, about 35 pills less. That's just in these 370 patients, about 13,000 pills out of our community. We're doing opioid drive on Saturday. We won't, I hope we can get more than that across 9 sites in 4 hours. We did that through one intervention from one surgery at one institution. So what are we doing? Well, we're leveraging a unique structure of Blue Cross Blue Shield funded collaboratives, something that makes Michigan unique and ready to tackle this problem as we think about acute care prescribing. I'll show the CDC mortality map, and I'll show you HOPE, because on top of that, I'll lay the 73 hospitals from this one collaborative. This is a general surgery collaborative representing every major hospital in the state of Michigan, coming together 3 times a year to talk about quality. And we feel very fortunate. We went to Michigan Department of Health and Human Services a little over a year ago and said, we would like to superimpose an opioid narrative on top of this really rich structure and talk about better prescribing. So I'm excited. Next week, we're going up to Boynton, and we're going to put out some prescribing recommendations. Heard a lot about prescribing limits today as I've met with people. They're important. They're an interesting topic. These are lower than all the proposed prescribing limits, and they will actually reduce prescribing in the vast majority of patients. And I don't think it's going to change pain. I don't think it's going to change refill rates. And I think we're going to be still attending to patients' care. And my sense is these are still conservative, and we're going to keep going down. Michigan guy, Saturday will come around here soon. But if I think about surgery alone in the state of Michigan, we estimate about 62 million unused pills. That's an error up there. 1.8 million surgeries, 62 million unused pills. So what would that look like? Well, you'd fill up the floor of the big house, but then you'd have to fill up 3/4. It goes from 1 year of unused pills from surgery alone in the state of Michigan. We work with this network of collaboratives. We are very fortunate to be funded by Michigan Department of Health and Human Services. We also have funding from SAMHSA and CDC and our state collaborations. And we're housed at IHPI, and this creates this rich structure of opportunity to meet and collaborate and talk about quality. So I want to leave you with something that we're also passionate about, and it's disposal. We know that our most at-risk populations are young. There's a tragic article in the New York Times earlier in the week about toddlers who are overdosing, rolling over on pills, heroin needles, methadone in water bottles. Terrible stories, but this is real. And then high school kids, teens getting access. We have done 5 opioid drives to date, 4 in Ann Arbor. Our last one was across the state. These are the data from our last one. We had 600 patients, about 420 pounds of pills across 5 sites in 4 hours. And most common reason for people to come back with surgery, our oldest drug, 1976. Sitting there in a medicine cabinet. The data don't lie. You can all go home. I'll challenge you to all go home tonight and look at your medicine cabinet. They're in there. You've got them in there. They're left over. So really happy this Saturday. We're going to have 9 sites across our state. We aspire to have more sites in the spring. So if you're in your community, you're saying, why isn't my site represented? I agree. Why is your site not represented? Come find us and we'll help you make your site part of our spring drive. We're excited and we think this will be our biggest event yet. We'd like to put ourselves out of business when it comes to opioid drives. Twice a year isn't going to cut it. We need to make this more of an everyday activity. So one of the ways we've done this is we had 2 staff. Jen Walgie led this with a couple of our staff who called every DEA registered site in the state of Michigan. And we've put this on our website. You can actually either put in your zip code or just scroll in our area and they'll tell you more about it. Broadly, we aspire to have more impact. This is not a pure research effort. We're interested in research, we're interested in quality, we're interested in education, and we're interested in our communities. We're doing some other things in terms of community outreach. I'm really excited. We just worked with the School of Voice and the School of Theater on Friday to bring in folks from Families Against Narcotics, a great group, who told their stories to these students. And I've already got a copy of a song that's been produced around that personal story of somebody with a robust addiction history. So we can create creative content to target teens and adolescents, primarily middle schools. We aspire to have those groups touring by the spring. We want to work with primary care physicians. This is definitely not just a surgery issue. Eventually, PCPs own this problem. And we also think this is really a cool opportunity to have public, private payers, and academics all working together on a really important issue. With that, I'll thank you. You can learn more about our organization and our efforts at Michigan Open. It is constantly being refreshed. Thanks.
So thanks to Amy, Rebecca, and Chad for 3 great presentations. Now we want to open it up for your thoughts, your questions, your concerns, your reactions to what you heard from our 3 speakers. And please introduce yourself and tell us where you're from.
I'm Tom Anderson. I'm from Grand Ledge, Michigan. And my question is, I don't really understand the physiology or the pathophysiology of an overdose death. And how we have the ones where they recover and they don't recover. What's going on with the medication and the chemistry of it?
Any one of our panelists want to take that?
I'll give the simple answer. You can maybe give the complicated anesthesia answer. Death from opioids happens because your breathing basically slows into a place until it stops.
Okay.
So, and that's basically it. So the overdose medication, you may hear Narcan, naloxone, when given, reverses that and allows the person to breathe more normally and wake up.
So does it affect the central nervous system? So that's what
that's
slows
exactly
the
right.
breathing?
So it
Okay.
slows the breathing. It basically is telling your body at some point to not breathe, and we need to breathe.
And our new challenge is that a lot of these medications that people are overdosing on, heroin, but now fentanyl and carfentanil, things that were used to come out of the hospital system, but now are being made in labs around our state, not legal labs. They are so potent and so fast-acting that that's the major difference. So you take a pill, it's a slower decline. These injectables lead to a much faster decline, and so sometimes people just aren't resuscitating in time.
Great. You'll hear the answers in the back. Is it great? Please.
Hi, Vince Bohnert. I'm an oral surgeon in East Lansing, and I have a question for Dr. Cunningham about MAPS. I routinely MAPS my patients now, especially since I'm on your PDOIC committee. And I just want to know when Michigan's going to really get serious about cracking down. Because last year the stat was 26 physicians had their licenses pulled because of over-prescribing. And I routinely MAPS my patients, and I will see 1 or 2 a week that's getting 120 Norco, 240 Norco prescription every month for the last, as far as I can go back. And to me, that just, I can't imagine a situation that would qualify for that.
So as I understand your question is, why are some physicians still prescribing very high doses?
Yeah.
I think if I rephrase that.
Numbers of pills.
And numbers of pills.
Yeah.
So I think we have an education task before us to educate. We have spent, when I trained, when many of us trained 20 years ago, it was very difficult to write narcotics. We wrote them on triplicate scripts, and we were trained that these were dangerous medications. That changed dramatically over the subsequent 5, 10, 15 years, and we now have an entire generation of prescribers who were taught actively that they needed to that they didn't prescribe pain medication, they were mean, bad doctors, that these medications were safe, and that we needed to give them much more liberally. And now here we are. And so we now have education in front of us to teach the habits that we've taught for prescribing to our young residents and trainees for 15 and 20 years, to teach them that these medications have substantial risk, that we don't know by any one patient what their risk is until we really look at the objective data and check the maps in front of us, because this epidemic doesn't have a clear socioeconomic, race, class issue. It crosses everything, that we need to check maps, use the objective data that's given, and then recently you've seen from MAPS, and many individual practices are giving feedback to providers, because I think most providers want to do the right thing and take good care of their patients, but they also may not realize where their patterns fall compared to their peers, and they need to be educated where they fall and then what safer prescribing is, hopefully with the kind of data that MOPN is putting forward.
Yeah, I'll just say that the only other thing I would add is that within the surgical prescribing, one thing we heard this morning was there's the top 25% of bad players, or 10% or 5%, whatever it is. When you look at surgical prescribing, and Jen and I were to grant around this, in a hysterectomy population, even the lowest quintile, the lowest group of prescribers as we categorize them, we're overprescribing by about 2-fold based on what we think people actually use. So I think there's different pieces to this narrative, right? And I think when it comes to surgery, dentistry, we see overprescribing not just in the highest cases, but across the board. And so I think, and with people who want to do it the right way and just don't know how to do it the right way, because frankly we haven't given them the information to make those decisions. Oral surgery and dentistry are very interesting and certainly a part of our focus. We're just kind of delving into that area.
Please.
I've had injuries and things that require sometimes some narcotics for pain management. One in particular, I really wrenched my knee bad, and I had an option though. They said we can put you through physical therapy or you can take pain meds. And at the time it was Celebrex, not a good thing. So I chose the physical therapy and I had to go, it was 3 times a week and it was really intense, but my knee healed and it prevented any further use of any pain medication. My point is, talking to several family members and people who get into injuries and they start with pain medicine, but when they have the option of doing the physical therapy that really heals the problem, there's so much involved as far as cost in doing it, and then it doesn't last enough to actually heal the injury, and then it becomes a thing about having to pay privately to sustain that. Is there anything going on around optional ways to manage pain which don't require drug use, and doing something about having access to physical therapy as an option?
Well, so I think it's a critical question. Congratulations to you for handling it the right way and making that decision, because it's not just the access; it's also the personal responsibility and that plan. Access is an issue in terms of physical therapy is not cheap, and it does take time. But I think you even have to go broader. I mean, there are behavioral therapies when we think about chronic pain conditions for which we struggle, at least in the pain clinic, sometimes to get people payment for. We offer free services because we believe in them. And I think expanded access to things like those behavioral therapies, which are not just talking about your childhood, they're actually teaching you how to manage your pain in probably a healthier way. And really, if you look at it, they work better than some pills if you apply them right. So thinking about more flexible platforms that include web-based tools, app-based tools that people can do these at home, because sometimes it's just not even just payment. It's do you have a provider in your area? And we certainly see parts of Michigan that struggle to find those providers. So it is incredibly complicated, but it's an important topic.
You got a question, we'll go to the back and to the side. Yes, please.
Okay. I'm Dr. Judy Seuss. I'm the medical director of a methadone clinic here in town. And at this point, most of our clients are funded by different portions of Medicaid. One thing they want us to do is after a year or more is just taper them down and off so they can say treatment finished.
They mean Medicaid.
I'm sorry?
They meaning Medicaid, like you have to get approval to continue
Yeah.
treatment past a year.
Yeah. My understanding is there is a percentage of individuals who do well on the daily methadone who will not be successfully tapered, that this is going to be perhaps lifelong or at least 10 to 20 years. And Medicaid doesn't really like that. Can you give me some idea on your thoughts on what percentage of individuals really for physiologic or genetic, whatever reasons, cannot be successfully tapered off or they will relapse?
So I think that's an area where there's a huge gap in our understanding. I think the reason for that is we're still grappling with how to make enough capacity for people to get into this treatment, that the question of when and how is the right time to stop it is hopefully soon, but I would guess 5 or 10 years from now people will really start to delve into that question. Because it's pressing to you and I, but for a lot of people that feels like a downstream question. So I think what you're saying is totally consistent with the evidence that any study where they compare, say, having people on methadone or on Suboxone for a period and then randomizing people to either be tapered at that point or to continue, the continue group is always doing better. So I think we don't know the point at which is good to stop. It's probably very variable between people. And if we can get funds to do research to say, how do you know when to stop? Or if to stop, there may be some people who shouldn't be stopped, but there are certainly people who do stop and do okay, like you said. So I think understanding those people better, what allowed them to stop, will be really important. And ultimately help, because there's some people who do well after 3 months, and could stop at that point. That could, if they're not encouraged to continue with the message, well, if you don't continue, you're clearly going to relapse.
that could free up resources for other people. So I think that's a really important question. You're right about the literature. I wish I had a better answer for you.
Hi, I'm Bobby from Relevant Recovery out of Greenville. We also have transitional housing called Randy's House. And with the MAT, I heard you speak of the methadone and the Suboxone, but no mention of the Vivitrol.
Yeah.
And I have a lot of clients that are very successful on the Vivitrol. And I just wondered if there was any numbers or research on that, why it's not out there more.
Yeah. I think it's still a little bit of a newer product. Sounds like you have really good experiences with it. I think it's still not used nearly as much. I am aware there was a recent study that it was observational, so it wasn't a clinical trial, but on average, the outcomes were not as good for the Vivitrol as it was for the methadone or the buprenorphine, and that was because patients were less adherent to it. So I think for patients who are really committed that that's the treatment they want, because for those who don't know about Vivitrol, it's a different medication. It reduces craving, but it's not an opiate. And you do it typically by injection once a month, right?
Correct, and then I believe it comes in a pill form after a certain amount of injections.
Yes.
But it blocks the opiate receptor of the desire.
Right, right. So it's more focused on blocking craving and not the preventing withdrawal the way that the methadone and buprenorphine do. I've also heard, I've not had it done personally, I've heard the injections are really painful. So I think that's one reason why people are reluctant to be adherent over it with the long term when they have to have multiple injections before they get to the point of using the pills. But it is so I think the mechanism, that's a downside, but it is a plus. If you only have to do an injection once a month, that's should be much easier to stay adherent to. So I think still needs to be some work done. It's a great option to have, but probably still some work done that will make a delivery of that will be more acceptable to patients or equally acceptable to patients.
Okay, and then I was wondering, I have a client that is weaning off the methadone to be on Suboxone, and this seems like a little craziness to me.
Like why who knows?
Yeah, because you still have an effect off from both Suboxone and methadone, and
Yes.
with the Vivitrol, you're not getting any feel-good receptors.
Yeah, the methadone and Suboxone are fairly similar pharmacologically and should have a similar effect. The outcomes when they've been compared to head is that they're equal. The methadone and the Suboxone are equally effective drugs. In terms of preventing abstinence, there's the thinking behind how Suboxone was developed and why it's allowed to be used in other types of clinical settings beyond just specialty addiction is that it is potentially a safer drug because of the naloxone component. It's much harder for a person to overdose when they're on it.
Well, the problem with the Suboxone would be that you have that choice to take it, or you can sell it on the street for a good amount.
Yeah.
And I would just say quickly to that, so there's a lot of discussions about which of those drugs are going to be best, but I would put forth the overarching message that many patients need one of those options to move to successful recovery. And a huge problem we have is getting people to any of those options at all. And for many patients, the option of no medication assistance and going it completely on their own leads to recoveries that are like 30% as opposed to that 70-80%. So which of those, I think, is a lot of the question, but we need to get more people to one of those treatments.
I think that's a very important take-home message. So,
thank you. I'm John Maxwell, Center Physical Agency. I think this is a question for Dr. Cunningham. Looking at this map where we have the statistically significant increase in death, is it just a quirk that most of those states are in the eastern half of the United States, or is there something going on that is leading those western states to not experience the death rate increase?
Well, a lot of those states already had fairly high rates, so what you might be seeing there is that they didn't have a big increase, but they were already at quite high rates. I think what we see is a national issue. There are certainly pockets and regions that have higher rates for a number of reasons that may have to do with drug trafficking or may have to do with how initial states' response was and the pieces. But the message across all those states is they're all quite high. We're seeing this isn't an issue in just the Northeast or just the Southwest. This is an issue across the country. And now it's up to the states of how we respond to see how we can stem the tide. And some states are more aggressive than other, and some states have implemented more options to both help people as well as to understand the data. So I think we want to be on the forefront of positive change for those numbers moving forward.
Yes, please.
As all these folks who prescribe these medicines are subject to licensure, are there, and this is indeed an epidemic, is there a systematic process by which medical societies or the university is reaching out with continuing education to make sure that every licensee has updated information and the latest advice on how to deal with this?
So I'll take it from the acute care prescribing side because I think it's probably ambitious for any single group other than maybe the state to say we're going to take on all of it. It's a big issue. On the Michigan Open we're in the process already of sort of re-educating surgeons throughout our state, and we will be starting through working with another nonprofit to talk about dental prescribing. That's an active area of participation. And the injury center's already done some great stuff in emergency medicine. So education is a key part. I've probably talked, between the three of us, I think we've probably spoken to 5,000 or 6,000 providers in the last 6 months of some varied interest and coming back for not single conversations. But I think that that provider-to-provider education and recommendation is critical to change. I can't agree more.
I was wondering if there's any kind of correlation between the decrease in prescription opioids and the increase in heroin overdose?
So that's definitely, yeah, I'll take that. That's an open question. So all of the data that has suggested a link there has been at the national level. And the challenge with that is that you can't differentiate between the effect of policies that are more restrictive on opioid prescribing and just what has been going on with we mentioned a couple times about the illicit fentanyl production and the increase in the amount of heroin that's being moved into the country that may or may not be related to demand for it because of people being tapered off of their opiates. There's a couple studies the CDC recently funded, including one that I'm leading at the University of Michigan to get at that question at a more patient level. So following individual patients and seeing if their losing access to opiates is associated with adverse heroin-related outcomes. So hopefully in a couple years from now, we'll be able to answer that more precisely. I'd say, just to add an opinion on top of it, I think if it's true, if there is an association there, sometimes that connection, or that theorized connection has been used to say, so therefore we should stop trying to fix opiate prescribing. I think if people are getting to a point where losing their access to opiates is causing them to turn to heroin, we didn't fail them by reducing their access to opiates, we failed them by not getting them the treatment.
Has there been any pushback from the pharmaceutical companies that they've lost 13,000 whatever it was pills being prescribed?
Yes, would be the short answer.
I think it's complicated, right? Because I think in the chronic pain space, if I stood up here as a chronic pain physician, there are some commonly used pharmaceutical names that would be of issue. The thing in the acute care space is these drugs are primarily manufactured by generic manufacturers. These are mostly generic medications. They tend to be pennies on the dollar. They are a commonly prescribed medication. But outside of the branded pharmaceuticals, which actually is a small portion of the opioid market, things like hydrocodone, oxycodone, they're generic and they're cheap. So I don't know. I probably won't get cards from them this holiday season. I'll be okay.
So that's definitely true of the generics. The brand name ones have a strong incentive to push against the policies that are reducing opioid dose. And I definitely get my strongest critics to my researcher from researchers working at pharmaceutical companies.
I get some interesting tweets every now and then. Yeah, there's some interesting tweets.
A lot of money involved.
Definitely.
Could you comment on some of the lawsuits we're starting to hear about some of the kind of earlier over-promotion of brand name opioids and sort of what effect that might have on sort of policy framework we're talking about.
I could start it. You probably have some thoughts too. I mean, I think there's little doubt that Purdue Pharmaceutical in particular was a bad actor in terms of pushing a narrative about the safety of medications that was not supported by any evidence. And they've paid out some lawsuits as a result of that, but it's a drop in the bucket compared to what they made financially off of that medication and off of that lie, essentially. I don't know where it will go through here, because Michigan recently announced a lawsuit, and there's definitely some momentum building. I don't know what you think about that.
I think it's interesting. States have been left holding the downstream effects and the costs of what was mismarketing. There's no ambiguity. There's a nice 4-part series in the LA Times from about a year ago that kind of goes through it and actually pulls out a lot of redacted information from through Freedom of Information Acts that's worth the read. It is seeing states come back and go after big pharma for money. I think it's interesting, and I'll say it that it's certainly a trend we're going to see, and I think that there's some validity in the approach. I mean, certainly the $600 million Purdue paid was a very small penalty in the bigger picture, and it wasn't just Purdue.
Right. Some are saying that the opioid-related costs may be handled much the way we've handled tobacco-related costs over the past 20 years.
Distinctly possible.
The major court cases and settlements around that. Yes, please.
In the midst of you're talking about using drugs to heal a drug problem, has anybody ever worked with biofeedback in the midst of changing the energetics that is creating the pain in the first place?
So I think I would say broadly, without answering specifically a biofeedback question, that one of the things that's come up as part of figuring out how to address this problem with people who have pain is that doctors, and to your physical therapy point as well as patients, need to understand that there's a broad toolkit of ways for people to get pain relief. Some of that might be physical therapy, perhaps it's biofeedback. And doctors need to be better versed and help educate our patients also in a multitude of ways to achieve better pain relief in addition to writing a script, which is simple and faster in kind of hectic times. And the other issues are more complex around how to get longer treatments paid for. So we need to develop a toolkit approach to pain control and have that socialized not only within the physician community, but also with our patients who very much expect, the same way people expect an antibiotic for every cold, people expect at this point pain medications for minor procedures, and we need to work with them on that.
Please.
My name is Lillian Heilig, and I work in the emergency department down the street at Sparrow Hospital. And just re-emphasizing the point of patient education and also the role of nursing is that, our physicians in the emergency department are trying not to just do narcotics as the first thing, but doing things like Ed says, there's Toradol and other medications before we go on to narcotics. I do try to educate my patients. Our goal is not to take your pain completely away. So there's something going on, and that we want to make your pain manageable. And then, just like you said, everybody expects an antibiotic for any kind of sickness they have, so many patients come in expecting a narcotic for something. So not every patient, but many patients do. So yes, that role of education is very important, and then also, sometimes they look at the script that the doctor says, gives them, are you only getting 6 pills? Yes, we're only getting 6 pills. Just encourage you to follow up with your primary care physician so that if you have more pain concerns, to get that treated. So just that education part is very, very important.
I think that's a good model. Do you have time for 1 or 2 more questions or comments? Yes.
Question, are you seeing differences between rural areas and urban areas in terms of
Yes, absolutely. So I mean, there's the rural areas have been, I think, hit some of the hardest in this country. This is a problem that crosses, as I said, demographics. It crosses class. It crosses race. It crosses regions. But certainly, some of the rural areas of this country have been hit the hardest.
They have the greatest degree of change. So it's not to say that it's not happening in cities, but their baseline rates of overdose were higher because heroin and cocaine use is more common in cities.
So let me ask our speakers, do you have a closing thought or take-home message that you'd like to share as we wrap up?
Sure. I mean, I think from the Michigan Open angle, we're interested in prevention. We're interested in that first exposure. And I guess my challenge to you would be two. One, go home, look in your medicine cabinet tonight, get them out. Go to the Michigan Open website if you want to find out where to get rid of them. If you're near one of our sites for our drive, we'll see you Saturday. And for the spring, I challenge you to find someone in your community. We've done all the work to make this easy. Join us for the spring. Let's get a true statewide drive together.
Great. I thank you all for your attention, and I encourage you to go, if you're interested in more resources or connecting with more people who have content expertise in this, to go to our Injury Center website and look at how to better connect with us and the general information that we send out regularly. I encourage people to think about both the MAP system, as well as we can be better utilizing that MAP system, both for physicians as well as for public health information sharing across professionals, so that we can get ahead of this epidemic. And also to think about both patients and providers and what we need to be doing to educate our communities as to other methods and strategies for pain management.
It sounded like there were a couple of physicians in the room, so I encourage people to think about whether Suboxone prescribing might be a part of their practice. We're definitely interested in doing some work to support physicians who want to start it, so be in touch with me if that's something you're interested in. And I think that's what we have.
Great. Well, thank you all for joining us today. And please join me in thanking
Marcia?